Okay, let's talk about this cool case of a patient presenting with multiple abdominal stab wounds. So this was a 17-year-old man who came into the ED. His chief complaint was abdominal pain. Initially, he would not admit what happened, but eventually revealed that he was stabbed earlier prior to arrival. He didn't want to tell his mother. He was stabbed once in the abdomen and twice in the back. Here you can see a picture of his abdominal stab wound, just lateral, left lateral to the umbilicus. He had no fever, chills, no nausea, vomiting, diarrhea, or constipation, and his tetanus was up to date. He's a teenager. On physical exam, his temperature is normal. His pulse is 97, so borderline. His blood pressure is okay. Respiratory rate is okay, and O2 sat 98% on room air. His general exam was well developed, no distress. His abdominal exam, we'll skip right to that. So on his left flank, he has two vertical stab wounds in the left flank, really. It says mid-abdomen, but really flank, with no active bleeding, diffusely tender in the area, hypoactive bowel sounds, and with mild tenderness, no rebound guarding or crepitus. He had a normal rectal exam, and he was hemocult negative, and a normal extremity and neurological exam. In the ER, he was given some IV fluids, morphine, and 1 gram of cefazolin. His wounds were irrigated and packed. A CBC, a complete blood count, a complete metabolic panel, liver enzymes, and coags were all within normal limits. Initial chest x-ray was within normal limits. Importantly, there's no pneumothorax or any evidence of thoracic injury here on the x-ray. And then a CT was ordered, but incomplete at the initial evaluation here. So let's talk about abdominal stab wounds. Okay, this is a penetrating trauma as opposed to a blunt trauma. The two major flavors are gunshots and stab wounds. There are, of course, others like shrapnel from an explosion or something, but the major penetrating trauma is gunshot wound or stab wound. Stab wounds are unsurprisingly much more common and associated with a lower mortality. They are also more likely to be missed because they can be hidden or subtle, or the patient may not even know they have it. The most common area is the left upper quadrant, and the liver, being the largest organ, is most frequently injured. About 20% of stab wounds involve multiple stab wounds. So stated differently, 80% are a single stab, 10% involve the chest, and about 3/4 penetrate the peritoneum. And then here's some anatomy, right? So you can see how big the liver is. Normally it crosses midline, the big target in the upper abdomen. Stomach is there, the spleen is tucked in the back. Those are the most vulnerable spots. And then of course, lower abdomen, you're gonna have large and small bowel be the big ones. Initial ED management is to follow ATLS and the trauma resuscitation algorithm. And this is because some patients with stab wounds will come in really sick, and you can't just zero in on the stab wound. You actually have to resuscitate the patient. So you want to start with recognizing that they have a potentially critical injury. Start resuscitating them. You do A is airway, B is breathing. So do they have bilateral breath sounds? Our patient did. Do they have good circulation, right? What is their heart rate? What is their blood pressure? What are their pulses in their extremities? D is disability. So what is their GCS, right? Are they mentating well is the bottom line. And then exposure. You want to see what's going on, anything you need to address immediately. So these patients are all stripped down the moment they arrive in the trauma bay. If you have to resuscitate them with fluids or blood or medications, or you need to put in a chest tube or needle decompression, or in the case of blunt trauma, a pelvic binder, like those kinds of things, that's in your primary survey treatment, essentially. And then you move on to your secondary survey where you're much more subtle and nuanced in your exam. In the case of stab wounds, your first thing is there a giant evisceration that requires surgical management, right? Does the patient seem peritonitic or critically ill? Is their abdomen distended and filled with fluid or blood or air? Are they hypotensive? Are they unstable? If they have blood in their rectum, it suggests some type of large or small bowel injury, right? There's blood traversing the large colon. If they have blood at the urethral meatus, then it suggests a GU injury, right? Is that the kidneys, the ureters, the bladder? You don't always know initially. If the patient is stable, then you can sort of locally explore the wounds, which is what we did with this patient. And if there's no penetration of the abdominal fascia, meaning the peritoneum was not entered, then it's generally not a surgical problem. Initial labs, in most cases, are going to be a complete blood count, a complete metabolic panel, and a coag panel. We didn't get a urinalysis on our patient because all his stab wounds were in the upper abdomen and flank. If it's a female, you want to make sure they're not pregnant. A blood gas can be very useful to sort of see how sick they are. And then certainly if you think they need blood, if you're even considering the possibility of blood, you send a type and screen. Imaging options. Initially, you're going to get an upright chest x-ray. You're going to do a fast exam, but again, they have to be bleeding pretty significantly to have a positive fast. And then CT is obviously a better test. You get to see the anatomy. It's more accurate. If they do need surgery, it helps the surgeons plan their approach when they get to the OR. And then, of course, if they're unstable or critically ill, you know that the stab wound has penetrated the peritoneum, that they have some type of bowel injury or liver injury, they're bleeding somewhere. Those patients just need to go to the OR, and you have to look and fix the problem before they bleed to death or get ill from sepsis. So here's a little treatment algorithm, right? Essentially, we'll follow this out. So if they're sick, right? So unstable peritonitis, evisceration, they just go to the OR, right? That's really not complicated. There is some subjectivity there, right? Maybe they're a little tachycardic, or they have a soft blood pressure, and you give them some fluids or blood, and then they're okay, right? But generally speaking, that's the dividing line. If they're stable, you can explore the wound locally, maybe just observe them after a careful exam that says they didn't enter the peritoneum. And then if they did, this says DPL, nobody does that anymore. So this should really say fast exam and or CT scan, depending on how sick they are. Okay. In the case of our patient, he had a penetrating intra-abdominal stab wound through the left rectus abdominis with small bowel herniation. You can see that here. This is an axial cut of his CT scan. This is the left side of his abdomen. This is his rectus abdominis right here. And you can see herniation of omentum and small bowel, and you can see a little bit of gas there, so you know that's bowel sitting in the abdominal wall through the rectus abdominis. Okay. So he went to the OR, right? You have to see if he has a small bowel injury. Fortunately, he didn't, right? So they just reduced the herniated bowel and repaired the muscle defect, and that's probably the best outcome you could have in that context. No bowel injury. The stab wounds were otherwise left open because they're kind of considered dirty wounds, and they need to sort of just heal by secondary intention. Patient went home on hospital day 3 and had a good outcome. The 3 key points about abdominal stab wounds. They're more common but less lethal than gunshot wounds and carry a much lower mortality rate. The most important thing is a thorough physical exam, including exposing the patient. Sometimes these are in the groin, under the testicles, in the armpits. You don't roll the patient both ways. You could miss one on the sort of upper back from the side you rolled to. So definitely need to be thorough there. And finally, evaluation requires labs and imaging. And that sort of is going to be dictated by how sick the patient is and where the injuries are. But you'll follow your ATLS algorithm, which includes laparotomy if the patient is critically ill.